All right, it's 2 o'clock, everyone. Welcome to Solara Grand Rounds. This is our inaugural episode of Soul Ed and Solara Neonatal Grand Rounds. Um, we really want Soul Ed and this whole endeavor to be a monthly educational series that's really focused on high yield neonatal topics, many of which have direct bedside relevance. I mean, you have to get something out of it, right? We want to understand physiology. We want to understand some clinical decision making, interdisciplinary collaboration, all with the purpose of just being better tomorrow than we are today. So today we have Dr. Sean Woods. Dr. Woods is a neonatologist with our team here. Many of you, probably all of you, know him well, and he'll speak on fetal and neonatal transition. But just to get you excited about what's upcoming, we have planning on doing an interdisciplinary case conference for February, which will be really focused around periviability and 23 to 24 week delivery, which we'll try to get our OB and MFM colleagues included into. Umbilical cord management and delayed cord clamping, some hot topics. And then Q2, we'll start getting into some pulmonary care and respiratory physiology. So surfactant biology, BPD, troubleshooting the jet and the oscillator. So hopefully all of these things will be really relevant to what we're trying to do every day, but also just interesting and piquing that inquisition to just get to know more. So with that said, thank you, Sean, for leading us today, and the floor is yours.
Hi, everybody. Nice to be with you this Friday afternoon. Really appreciate you joining for our first Solara Grand Rounds, and I hope it's something that is digestible and something you can take to the bedside and take something away. Today's topic is neonatal transition, physiology, and motion. The first hours after birth represent one of the most rapid physiologic transitions in human life. And how well a newborn adapts during this period determines much of what we see in the NICU and in the nursery. Birth is a powerful moment, not just medically, but emotionally, both for the baby and the family. Most newborns transition from fetal to extrauterine life with no difficulty at all. But that doesn't mean the process is simple. In the first minutes and hours after birth, the baby undergoes enormous physiologic changes, and a number of fetal, maternal, and perinatal factors can either support or complicate that transition. Understanding those factors helps us prepare for a delivery and for us to care for newborns more thoughtfully. This session today is really about three things. First, how we support families and newborns during the normal transition, because most babies do well, and how we care for them matters. Second, we'll talk about evidence-based strategies that promote newborn health during those first critical hours. And third, we'll focus on how to recognize when the transition is becoming compromised or failing, so we can respond early and appropriately. We'll also touch briefly on why this matters, not just in the moment, but also for longer-term outcomes. And one thing this session is not is a deep dive into persistent pulmonary hypertension or a review of NRP, so no worries. Epigenetics is this useful framework for thinking about the newborn transition in a way that goes beyond anatomy or vital signs or isolated interventions. The core idea is that birth represents a powerful biological signal, one that can influence gene expression without changing the underlying genetic code. During the intrapartum and immediate postnatal period, the newborn is exposed to a whole series of physiologic stressors. These help drive adaptation to extrauterine life. These stressors exist on a spectrum, and importantly, not all stress is harmful. Normal physiologic labor is associated with coordinated increases in cortisol, catecholamines, and oxytocin. And these hormonal changes contribute to lung fluid clearance, cardiovascular adaptation, thermoregulation, feeding readiness, and early bonding behaviors. From this perspective, labor is not just a mechanical process. It functions like a biological preparation for the newborn's transition to extrauterine life. When birth differs from normal physiology, whether because of the mode of delivery or necessary medical interventions or early postnatal separation, these hormonal and physiologic signals can be altered, and emerging research suggests that these differences from the normal physiology can influence the immune function, metabolic regulation, and stress responsiveness later in life. Much of the evidence is observational, and of course, the interventions can often be life-saving, but the data remind us that early life events can have biological effects that extend beyond the immediate newborn period. So this framework highlights why the care during transition is not simply supportive, but it's biologically meaningful. The decisions that we make as a clinical team, how we support breathing, how we manage temperature, how we handle separation, how we facilitate early parent to infant contact, these all interact with the newborn's adaptive physiology. Practices like skin to skin contact, minimizing unnecessary separation, gentle breathing support, supporting early feeding, these can reinforce the physiologic pathways in the newborn and in the mother. And in that sense, the interdisciplinary care during the transition plays a direct role in shaping how successfully a newborn adapts. The first hour after birth is not random. Studies of newborns that are skin to skin and aren't being disturbed show that infants demonstrate a series of common and sequential behaviors. These behaviors occur in a predictable order during the first hour of life, and each phase appears to serve a physiologic purpose. Rather than thinking of this period as unstructured time, it's more like an organized process that supports the transition. The first phase is crying at birth, plays an important role in clearing the remaining lung fluid. And this is followed by a brief relaxation phase when the infant becomes quiet and still. Over the next several minutes, baby enters periods of awakening and activity, opening the eyes, moving the head, showing early feeding cues. Later phases include rest, crawling towards the breast, familiarization, and eventually self-directed suckling. By about 70 minutes of life, most infants enter a sleeping phase, and this is part of why initiating feeding earlier in this sequence tends to be more successful. Right after birth, healthy newborns don't immediately settle into a steady state. They progress through this predictable sequence of events as they recover from the stress of birth and they adapt to extrauterine life. The period is very dynamic, with coordinated changes in the heart rate, respiratory pattern, color, temperature, behavior. The classic neonatal transition is done in 3 stages, each with physiologic and clinical features. And understanding these stages helps us to recognize what is normal and identify when a transition is becoming abnormal. The first stage, occurring in the first 30 minutes after birth, is known as the first period of reactivity. During this time, the heart rate rises, breathing is often irregular, and there are signs like crackles, grunting. Infants are typically alert and active and responsive, but the body temperature can fall as they adjust to extrauterine life. This is followed by the second stage, about 30 minutes to 2 hours of life, characterized by decreased responsiveness. During this time, the newborn often sleeps, vital signs become stable, breathing becomes more regular, and overall the activity decreases. The third stage, or the second period of reactivity, this third stage is between 2 to 8 hours of life, and the responsiveness comes back, heart and respiratory rates become labile, secretions can increase, and feeding cues often become more apparent. And these stages are normal, but when the features are exaggerated or prolonged or even absent, they can signal a compromised transition. So we will have some physiology and pathophysiology to kind of review. Before birth, the fetus is entirely dependent on the placenta for oxygen delivery and waste removal. The fetal lungs are structurally developed near term, but they're not involved in gas exchange, and they have a very high pulmonary vascular resistance. As a result, less than 10% of the cardiac output flows through the lungs. Instead, blood flow is redirected through three key fetal shunts: the ductus venosus in the liver, the foramen ovale in the heart, and the ductus arteriosus, all of which transfers blood from the placenta directly into the baby's systemic circulation. So it kind of goes from right, where the placenta is on the right side, to the left. And all of this optimizes oxygen delivery to the vital organs like the brain while bypassing the lungs. At birth, the responsibility for gas exchange transfers from the placenta to the lungs. And with the first effective breaths, the alveoli aerate, lung fluid is displaced, and the pulmonary vascular resistance falls rapidly. So this results in a tenfold increase in pulmonary blood flow. As this blood flow increases to the lungs, it comes back to the heart, and the left atrial pressure rises, exceeds the right atrial pressure, and that leads to the closing of the foramen ovale. At the same time, the umbilical cord becomes clamped, which removes the low resistance circuit of the placenta. Then the systemic vascular resistance increases, and this further reshapes the circulation. As the systemic vascular resistance rises and the pulmonary vascular resistance continues to fall, the right to left shunting that I mentioned, it stops. Blood flow across the ductus reverses directions, and the functional closure of the ductus occurs in response to increasing oxygen and decreasing circulating prostaglandins. At the same time, the lung fluid has to be cleared to allow for effective gas exchange, which occurs from a combination of mechanical forces, such as the vaginal squeeze and crying, as well as reabsorption of fluid through the epithelium, and hormonal changes, these big surges in cortisol and catecholamines that happen during labor. Successful clearance of the lung fluid is required so that the alveoli can be recruited and filled up with air, and to establish the functional residual capacity, essential for stable respiration. One example of how we can support physiologic transition is the practice of delayed cord clamping. At birth, the placenta continues to transfuse toward the baby. The blood flow continues toward the baby. And so the practice of delayed cord clamping is known to increase the blood volume of the neonate, resulting in higher hemoglobin and higher iron stores. This practice supports cardiovascular stability, and it's well recognized as safe for vigorous term and preterm infants. There is now a large body of evidence supporting the practice of delayed cord clamping. Studies have consistently showed higher blood volume and hemoglobin levels, iron stores, and in terms of outcomes, this practice has been shown to decrease the need for a blood transfusion in preterm infants, as well as to lower rates of intraventricular hemorrhage. These benefits are balanced with what's described in the literature as a small but present increased risk for hyperbilirubinemia, jaundice requiring phototherapy. Um, Delayed cord clamping might not be appropriate if immediate resuscitation is required or if the placenta or maternal instability is thought to be present. While most newborns transition successfully, about 10% require some degree of assistance after birth to initiate or sustain effective breathing effort. Respiratory distress is one of the most common complications of the early neonatal period and is a major contributor of morbidity, mortality. Um, there are many causes like surfactant deficiency, retained fetal lung fluid, etc. But the consequences tend to converge: impaired oxygen delivery to the vital organs, inadequate ventilation, retention of carbon dioxide, and disruption of normal acid-base balance. Respiratory distress can occur as an isolated problem or as part of a broader systemic condition. Respiratory distress in the newborn is seen clinically, often before any diagnostic testing is done. Tachypnea, defined as a breathing rate greater than 60, is often the earliest sign. Grunting represents an attempt to maintain alveolar pressure and improve gas exchange. Retractions reflect the increased work of breathing against a compliant chest wall. Nasal flaring functions to decrease airway resistance and increase airflow. Hypoxemia can be detected non-invasively by pulse oximetry, but the changes in color, like pallor or cyanosis, are the important clinical indicators. Color assessment in a newborn requires careful interpretation. Acrocyanosis is the common finding in the first 24 hours and often reflects peripheral vasoconstriction or cold stress. Central cyanosis, however, involves the skin and the nail beds and the mucous membranes and is a late and serious sign. Because of the presence of fetal hemoglobin, a newborn has to be significantly desaturated before cyanosis becomes visible. So color assessment can be an unreliable early marker of hypoxemia. The amount of hypoxemia necessary to make cyanosis become actually visible. Moving on, thermoregulation. This is a critical component of the newborn transition. At birth, infants move abruptly from a warm intrauterine environment to the cooler ambient temperatures, and they have to actively generate and conserve heat. Term babies rely on a combination of stored fat, oxidative metabolism, and non-shivering thermogenesis from brown fat, as well as muscle activity and peripheral vasoconstriction. Even with these mechanisms, healthy term babies remain vulnerable to heat loss because of their relatively large surface area, their immature skin barrier, and the fact that they're born wet with amniotic fluid. Heat loss occurs in newborns through 4 well-described mechanisms: conduction, convection, evaporation, and radiation. Conduction involves direct contact with the cooler surfaces like a cold scale or a blanket. Convection occurs through air movement, like drafts in the delivery room. Evaporative heat loss is especially important right after birth when the newborn is wet. And radiant heat loss occurs when the heat is transferred from the infant to cooler objects nearby. When heat loss exceeds an infant's ability to conserve or generate heat, the newborn experiences cold stress and can become hypothermic. Hypothermia, defined as an axillary temperature below about 36.3 to 36.5. Cold stress has important physiologic consequences, including increased oxygen and glucose consumption, depletion of energy stores, pulmonary vasoconstriction, and hypoxemia and metabolic acidosis. So preventing heat loss is therefore a key part of supporting the normal transition. Skin-to-skin contact is one of the most effective strategies, and it's been shown in some settings to be as effective as incubators or radiant warmers for preventing and treating hypothermia. Newborns are not passive at birth. Both the fetus and the newborn have well-developed sensory pathways that allow them to experience and interact with their environment. Newborns can recognize their parents' voices, they turn toward familiar sounds, they demonstrate a clear preference for their mother's face and scent. Their visual acuity is limited in range, but it's well matched to face-to-face interaction. It's one of my favorite things to share with breastfeeding mothers, that her newborn's visual focus is the exact distance from the breastfeeding to the mother's face. They can see the face. Smell and taste are especially important. Newborns can localize smells. They can orient toward the smell of breast milk, and they show a preference for sweet tastes. Newborn behavior follows predictable cycles of sleep and alertness. These states are not arbitrary. They reflect the underlying neurologic and physiologic regulation. Each state is associated with differences in responsiveness, breathing pattern, oxygen consumption, and readiness to feed. So recognizing these states helps us to understand when infants are most capable of interaction and learning. The quiet alert state, so-called, deserves special attention. So right after birth, term newborns often enter this period of quiet alertness. This is their first opportunity to take in their parents, the environment, and during this state, the infants are maximally attentive with minimal motor activity. And so this is the optimal time for interaction, feeding, and bonding. And simple environmental adjustments like dimming the lights, using quiet voices, gentle handling, all help to preserve this state. Next topic is about glucose regulation, an important part of the newborn transition, but it's an area where definitions of normal and abnormal are not universally agreed upon. At birth, the newborn's blood glucose is approximately 70% of the maternal value, and that relationship is linear. It doesn't change over time. So it's almost always right about the 70% of the maternal value at the time of birth. In the first hour, the glucose level can fall dramatically, sometimes as low as 25, even in otherwise healthy and asymptomatic babies. These early decreases are thought to play a role in triggering the normal metabolic adaptations like gluconeogenesis and the use of fat as an energy source. Because we don't have a single clear threshold that predicts harm for low blood sugar, the current practice relies on what are called age-based operational thresholds to guide intervention. Within the first 4 hours after birth, glucose values below 25 to 35 should prompt consideration of glucose support, and from 4 to 24 hours, the operational threshold increases to about 35 to 45. Most asymptomatic infants can be managed with early and frequent feeding, while any symptomatic infant most likely requires prompt treatment with intravenous dextrose. Two small interventions with really a huge impact. Newborns are born with extremely low vitamin K stores, meaning several key clotting factors are functionally deficient at birth. A single IM dose of vitamin K nearly eliminates the risk of late and often catastrophic intracranial hemorrhage. Eye prophylaxis is similar. It's not about treating an infection that we see every day, but about preventing a rare and potentially blinding disease, gonococcal conjunctivitis, which can cause corneal injury within days. And a single application of the ointment provides protection at the population level. I think one more kind of clinical topic in terms of transition is related to bilirubin, another um, uh, area that the baby has to undergo transition. So before birth, bilirubin is still being produced by the fetus, but it exits via the placenta. And after the delivery, that pathway through the placenta closes right away. So the newborn has to rapidly switch to uptake of bilirubin in the liver and conjugation so that it can be excreted through the GI tract in the stool. So what is conjugation? We use that term frequently. Conjugation is in the liver, an enzyme just kind of sticks a extra protein onto the bilirubin so that they become conjugated together. And that makes a change such that it can be excreted into the stool. So the bilirubin transition is normal. Every baby goes through it, but it's temporarily inefficient. And this results in physiologic jaundice. I like to think about it or explain it in terms of filling up a bucket with a hole in the bottom. So the hose is always producing bilirubin at a steady state. It's always making more, or it's always, making bilirubin. But the hole in the bottom of the bucket is the way of getting rid of it. And it's this balance that results in filling up the bucket or emptying it. So here the hole in the bottom of the bucket can either be the placenta during the pregnancy, so that this bucket never fills up with water at all. But then after the delivery, there has to be a new method of emptying it out. And that new method takes time to develop. I want to briefly mention this topic that across the cultures, families mark the arrival of a newborn in very different ways, often through social, spiritual, or religious rituals. In many cultures, these welcoming practices are delayed for weeks or even months, reflecting the historical concerns about newborn vulnerability, infection prevention, and the mother's need for recovery. For example, in parts of Asia and Latin America, a rest period of 20 to 40 days after birth is commonly observed, often with partial or complete seclusion and support from the extended family or community members. Some practices that appear symbolic have evolved to be physiologically protective, such as Jewish circumcision at 8 days of life, timed to more reliable vitamin K dependent clotting. Families may also describe their newborns using language that reflects spiritual or intergenerational beliefs, such as referring to the baby as arriving earthside. When beliefs or practices are unfamiliar, our role is to take the lead from the families, ask them questions, clarify their preferences, choose language thoughtfully, and avoid assumptions. Cultural humility during the newborn transition is not about knowing every tradition, it's about knowing how to listen. Ongoing infant care and feeding can be challenging, especially for inexperienced families that are negotiating with sleep deprivation, major life transitions. Parenting requires cognitive, motor, social, behavior skill development. And what's striking is that parental confidence strongly correlates with long-term parenting satisfaction and health behaviors and positive parent-infant interaction. We also know that gaps in caregiver education show up clinically, Reviews of non-acute emergency visits in neonates consistently show that the most common reasons that families seek care are jaundice, irritability, and emesis, concerns that are often appropriate but not always urgent. Importantly, improved caregiver education and postnatal support can reduce these visits. Beyond routine care, families need to understand what normal looks like, what isn't normal, and when symptoms require immediate evaluation versus next day follow-up, for example. So effective newborn care doesn't end at physiologic stability. It extends to equipping families with the knowledge and confidence to care for their infant safely at home. I know this was a very broad overview. I didn't want to dive too deep. We can, maybe have questions or comments, or see if there's any, if this brought up any thoughts. But the neonatal transition period is this critical window for recognizing normal physiologic adaptation and identifying early signs of instability. Carefully observing and assessing babies and being thoughtful about supportive management like respiratory, these all form the foundation for a safe transition to extrauterine life. Most newborns complete the transition within the first hours after birth, and those who do not tend to declare themselves early. A steady and attentive provider presence supports both the newborn stability and the adjustment of the mother-baby dyad. Thank you for your attention. Really appreciate you joining in. I put the rest of our topics right here.
Yeah, thank you so much, Sean. And, definitely open it up for questions, but I guess I can start because I am always so incredibly fascinated by neonatal transitional physiology, like all of the things that have to happen for that baby to be, quote, normal, which happens 90% of the time, right? Are just phenomenal. I know you mentioned vaginal squeeze, and that's just a trigger word for me personally. But perhaps, we have a situation where you have a C-section, it's an elective repeat, and the baby didn't get that vaginal squeeze. Is that really how babies clear fluid, or can you talk a little bit about how lung clearance works a little bit? Just because I think that's taught maybe a little bit more than perhaps it's truly responsible for.
Absolutely, yeah. There's a very common misconception that would be excellent if your main takeaway from this talk was to get the facts straight on this topic, because it's very common, and we talk to families a lot about it, and that is TTN, or retained fetal lung fluid, one of the most common causes of a NICU admission. And during pregnancy, the lungs are filled with fluid, of course. But this is not amniotic fluid that is breathed in or swallowed. No, it's not at all. In fact, which is, by the way, another common misconception. The fluid in the lungs of a fetus is made by the lungs. It's called a proprietary lung fluid. It has a totally different concentration of chloride, and it is actively produced, and it comes up and out of the airway. So it's constantly being produced, and it's flowing up the trachea and out, not the other direction. As the fetus approaches the labor and delivery, they have to clear all that fluid out and fill the lungs up with air. So the first step is to clear the fetal lung fluid. And that process begins well before the baby enters the birth canal. There are genetic, gene expression changes that occur even before the onset of labor. So the baby kind of knows it's going to be born and starts changing its fetal lung fluid production, and it makes these new protein channels that are designed to reabsorb lung fluid into the body. And when the actual labor starts, the baby gets the surge of epinephrine and cortisol, the hormone changes that I mentioned earlier, and those really upregulate the fluid channels that help to start and continue reabsorbing the lung fluid. So when the contractions are going, the baby's not being mechanically squeezed at that point. Just the uterus is contracting, but the chest is not being mechanically squeezed. But all that stress is the fluid is being reabsorbed even during that time. And when the baby is passing through the birth canal, there are mechanical forces that contribute to fetal lung fluid reabsorption, but they are a minor component. And so to say that, so there's the component, the mechanical, and then after the baby is born, still about some fraction, maybe up to a third of the fluid is still in those lungs. And that's the importance of the first breaths. Babies take these big negative pressure breaths that push the fluid more into the reabsorption. And so all of those stages are important. The hormone changes during labor are critical for lung fluid absorption. So the elective C-section at 37 weeks results in retained fetal lung fluid, not because the baby doesn't have the mechanical forces of vaginal squeeze. That would be a small but technically part of the story, but more so that they don't have the physiologic effects of labor.
That's awesome. Thank you so much. We'll open it up to questions. You should be able to either unmute. If you can't, just raise your hand and I can try to allow your mic to go live here too. If there aren't other questions, Sean, I'll throw you another one here because I think we're seeing this more and more about vitamin K, and we're having to have conversations with families that maybe we didn't have even 6 months ago or a year ago. How do you approach that? So a family comes, you're seeing them as a well newborn and they refuse vitamin K. Maybe if you could give the audience here just a couple tips or tricks or just kind of how to approach that to them, just to just talk to them about the importance. And I know it's a tough conversation, but would love to hear any insight that you have on that.
Every hospital will have its own policies and forms and things like that. So I would have to speak generally and say that when talking with a family that wants to refuse vitamin K, I try to be open-minded. I'm just kind of share my personal attitude toward it, which is that I recognize that when I am meeting with a family that's planning to decline vitamin K, that the baby is most likely not going to receive vitamin K. And when I know that, I can move forward and just recognize what my role is, what the parent's role is. And I don't know, I just try to do a reset of, what my role is in this situation. And I'll often clarify that to the family. I use very open-ended terminology or tone of voice, and I explain to them, reiterate what is obvious and true, which is that this is their baby, and they have the responsibility to make decisions about the health care of their child. And just to, that they know that, of course, but by acknowledging it, you can have a conversation. So one of the first things I do is to acknowledge that the parents have primacy of decision making, and my role is to share my professional opinion, my medical opinion, and then I try to feel them out, see what they say, because every family is different. There are families that refuse vitamin K from idea of medical non-intervention and sort of distrust of medical intervention. But then occasionally there are families that have some myth that they've heard about. So there are. That's why I say it's best to listen, is to get a sense from them of where they're coming to this from, because you really have to tailor the actual advice family to family. If I had a family told me that they were worried that vitamin K results in an increased risk of childhood leukemia based on observational study from England in the past. Okay, now I understand that this worry comes from something quite specific, and maybe I can provide information to help them understand where that idea came from and why we don't think that it's true, why it's not true. Other families maybe have a religious belief about the reasoning, and so it's just so important to be open-minded and try to get a sense of where the family is coming from. And then the medical advice that I give is the family does need to be informed that about the quite serious risks. So I present some type of like my analysis of the risk-benefit decision for administering vitamin K to a baby.
Yeah, that's a great approach. Thank you for that. I think it's very natural for us to get defensive in those moments, right? Like, and I think your approach of, well, they're making the decision, and the reality is very true that we are very unlikely to convince them of a different decision. We may 10-15% of the time, and we'll take those wins, but to have an open-ended conversation and a respectful conversation, and try as providers at all levels to not have judgment, but just have an opportunity for education, right? And kind of balance. So it looks like there was a comment just about, given we're all in the TikTok world, which we are, but in fact, there was a good pediatric ER doctor who does a really good conversation on vitamin K and CT images. So yeah, sometimes we have to use those same resources to put it back to say, yes, you got your information from this source, but perhaps listen to another another talk on this exact platform that they're getting some of their initial information from. So thank you for that. We'll definitely share it. And then we only have a couple more minutes left. Anybody else have other questions, thoughts, conversations, topics they want to bring up? And if you can't speak, again, please type it in the chat or raise your hand. All right, Sean. Well, if there's one other kudo thing you want to leave the team with in terms of takeaway from today, what would be your last pearl or takeaway from this presentation that you want them to walk away with today?
I guess maybe the just to be aware of the different, to be mindful about how every family can approach birth in a different way, and to be open that the newborn transition is really an impactful time for families. So learn from them what they're expecting and what their concerns are, and that way, now that you're equipped or reviewed with the knowledge of transition, you can help them and kind of meet them where they are.
Awesome. Well, thank you all for joining our first Solara Grand Rounds. Definitely appreciate the turnout. This is recorded and it should get sent to you afterwards. Feel free to share it. And then we'll go ahead and send another invite for the next one in February. Always welcome feedback, so please give that back directly to myself or Dr. Woods in terms of either future topics or just how you'd like us to approach it going forward. So thank you again for tuning in, and we'll be in touch. See you guys soon.